This course will include detailed discussions, injuries, and anatomical structures that may be graphic or disturbing to some viewers.
This is Dr. Axine here. We just got here to San Diego. Just kind of walking around, checking out the beautiful weather. Super excited about our video we're going to be shooting tomorrow. We're going to be learning about hemorrhage management, blood loss.
Bull sharks, white sharks, and tiger sharks. Those are the three big ones. And because of their behavior, because of the size of their teeth, they can inflict fairly substantial wounds on people.
And instantly, I just started screaming for help. I was just, help me, grabbed my arm like this, and just started swimming this way. And then all I hear is the guy on the kayak just go, oh shit.
You know, at Axine CE, what we try to do is to make learning fun and to bring you places like this, out to the ocean. We're actually going to film on site in the ocean where this patient was bit by a great white. It's going to be amazing. I am actually very nervous. Just being honest, I thought I'd record this. I wasn't asked to record this, but I hope it goes well. I'm sure it will. The odds are really low I'll even see a shark, but I am nervous. See in a moment,
yes,
how the odds are stacked against you in the
yes.
ocean.
Yes.
I mean, it's ugly.
Oof, you don't even see it coming. All right, let's. My name is Matt Ball, by the way. I'm a firefighter, paramedic, registered nurse here in the Dallas area.
My name's Eric Axine. I'm an idiot, and I'm an ER doctor and EMS medical director. It's an honor to be here today.
You're brave. That's it. You're courageous.
No, actually, you know what I am? I'm willing to sacrifice to learn. We got to engage our students.
That's true. Well, let's hit some objectives.
So we're going to list the major mechanisms for hemorrhage.
Yep, and then we're going to recognize compensation patterns linked to blood loss.
And this is probably the most important of the three, is to be able to assess patients with life-threatening hemorrhage. Being able to identify a hemorrhage emergency is super important. And we actually get to talk to a shark bite victim.
That's
that
right.
Dr. Schwartz introduced us to.
Yes, Keen Hayes, right?
Keen Hayes,
yes,
yeah.
Amazing
Boy,
young man.
Inspiring, yeah.
Yes.
And so we're going to use that story through the 2-hour lecture that we're going to put together.
About a week before, every Wednesday, I used to go to this youth group called Pipeline that's just down the street. And I went every week, had a bunch of friends, and I had this one friend, his name was Noah Hartman, and we decided to go lobster diving at Beacons Beach on that coming Saturday, so in a couple days. Wake up that Saturday morning at probably 5:30, go into my mom's room. She's like, Mom, okay, let's go. Get ready, you're gonna take me. And she's like, all right, fine. She was hesitant. And going up to Beacons, you go up this hill and then you take a turn, and then the parking lot is right there. It's kind of like a blind corner. Noah finally came, got his stuff on. I think we took a picture or two, and our parents talked for a little bit. I was like, to my mom, I just said, okay, you can leave me. I'll see you later, and you can come. I'll text you when I'm done. You can just come pick me up.
I will say this, though, before we get into this horrific reality of these predators, is that sharks really are amazing, and Dr. Lowe actually helped us to really appreciate these animals.
Yeah.
And they're either protecting themselves, or they just it's like a mistaken identity thing.
Thinking you're food.
but unfortunately, the results could be catastrophic. When you're dealing with 5 rows of 2-inch long teeth and a 23-foot long man-eater.
Weighs 1,000 pounds and has a bite pressure of 4,000 psi.
No, a lot more than just 1,000 pounds. I mean, these things weigh tons.
Yes,
I mean,
depending on the size. Yes,
4,000 pounds.
That's like one of the strongest bites of any animal, correct?
It is, with 5 rows of 2-inch long daggers. I mean, it's no wonder why these ER doctors we talk to describe these injuries as like a blast wound from a grenade.
Yeah, more like a combat style injury.
Yeah.
And we're gonna in the second half we're gonna see some.
But this
examples of that.
This was actually one of the most horrifying things to me, is that I didn't realize how. I mean, do you know how fast a human swims? Like Michael Phelps, how fast does he swim?
Michael Phelps, how fast?
Olympic swimmer, fastest swimmer on the planet.
Yeah, just a freak
How many
nature.
gold medals? Like 1 million gold medals?
Something like that. Yeah. I would guess he swims, I don't know, 25, 30 miles an hour, maybe?
5. He swims 5. 5 miles.
5 miles an hour?
Mm-hmm.
That's it?
That's it. That's the Olympic swimmer, 5 miles an hour.
That's it?
Yeah.
Oh, I wouldn't have thought that.
Great weight. Sorry, Michael. 46 miles an hour. That's how fast these guys are. I mean, they're really meant for speed underwater and power. And some of the stories,
insane.
and actually, when we get to cases in Unit 2, there's some amazing things that happen with these animals and what they do with their bodies.
Oh, that's amazing.
Here's the scariest thing, though, to me. These ampullae of Lorenzini, these receptors around their face and around their mouth are about 1,500 of them. They're able to detect little minute voltage differences. It would be very, very small. It would be like being able to detect 2 AA batteries getting connected 1,000 miles away. Now, and I talked... Serious. I mean, that's crazy, right?
That's
Dr.
insane.
Lowe and I talked about this, and he goes, that's not realistic, and, it's kind of whatever. That might be the physics of it.
Right.
The reality is that's not what sharks are doing. They're not doing that.
Right.
Sharks actually have these electroreceptors to kind of position their mouth around their prey.
Right.
So they can see an electrical picture like a bat sees a sound picture.
Right.
Sharks see an electrical picture, and they can detect up to 4 billionths of a volt in changes. 4 billionths. I mean, that's a tiny bit of electricity. They can understand and see that voltage difference. That's small. So as I'm sitting out there in the ocean
terrifying.
waiting for our media director Devin to get his crap together,
Waiting for
with
your
the
legs
drone,
to be bit off.
I'm thinking about this. Like, I got my body, an electrical system in the water. These guys are seeing me, a mile away, and they're like
1,000 miles away. Yeah, they're seeing you from like Maine on the coast of California. They're like, I'm going to swim around and bite that doctor's legs off.
Hey, speaking of Dr. Lowe, we should meet Dr. Lowe.
So bull sharks are a common species that are found along many coastlines. They get to be up around 10 or 11 feet long, and they have fairly large teeth. They're a robust shark. They're a big shark. They're called bull sharks for a reason. They're like a bull. But they're also unique in that they can enter fresh water. So they can enter freshwater systems where people don't expect to encounter sharks. So that's one that quite often in estuaries and in rivers, people can occasionally be bitten by sharks, and it's a surprise. Tiger sharks and white sharks, however, are oceanic. They're typically found around coastlines, but can also be found offshore, and they can get quite large. Tiger sharks can get up to 16 feet long, white sharks up to 23 feet long. And we're talking about teeth, that dentition that gets up to 2 inches long. That's a big blade on that knife. So when you look at the biting pressure and you look at the size of the tooth, you can begin to understand the magnitude of the injury that they can create.
So he talked about bull sharks and how they can kind of swim up fresh water.
He didn't say it, but we learned that bull sharks have been as far north in the Mississippi as Chicago.
Yeah, being from that area, I've heard that. But now it's been confirmed from the world's leading shark expert.
Not common, but possible, and it's been documented apparently. But anyway,
Right.
But the magnitude of the injury that he's talking about. I mean, we don't have to have a shark bite. I mean, the most common mechanism would be motor vehicle accidents and violence. The most common types or causes of fatal hemorrhages.
Right. And as, responders across the country, obviously if you're not working, on a ocean shoreline, whether it's East Coast or West Coast, you're probably not going to run into shark bite victims. But, MVAs and violence, these are calls that we run on, pretty much daily. 90% of these injuries occur in low to middle income nations.
Correct.
So obviously, you go to a third world country, which you and I have both done that.
Access.
It's there's a lot of factors that play into that, but they're more prone to those type of injuries.
And even in those rural communities, if you're in a rural agency with the longer transport times and longer response times, just by nature of location, these injuries can be devastating if you the chainsaw or you go. I mean, there's so many things that can happen.
That's why it's important, like we said at the beginning, to recognize that your patient's at risk for a life-threatening hemorrhage, and be able to identify that, manage it, and transport them quickly, which we're going to talk more about.
And from an epidemiology standpoint, the traumatic hemorrhage is actually the leading cause of death in folks under 46, which makes sense.
Yeah, it makes total sense. Yeah, exactly. Older folks aren't engaging in risky behavior.
Not as much.
Like swimming with great white sharks.
Nobody would ever do that.
And then traumatic injuries account for 12% of global disease burden. So it's
significant.
Yeah, that's pretty significant. Yeah, when you go worldwide, it's a...
And we do have some international students that watch us in other countries. So wherever you are.
Some interesting statistics. Yep. So there's different mechanisms for massive blood loss, right? Yeah. We're going to kind of go through those.
Yeah, so obstetric, postpartum, and antepartum. Yeah. Some of the scariest patients I've ever treated in the ER, bleeding early mommies or new mommies or whatever.
Yeah. And I think when we get these calls as first responders, I know myself included, our main concern usually is the baby. Yeah. We're terrified of the baby crashing, or having to work a neonate, cardiac arrest. And sometimes we neglect how dangerous this can be for mom. Obviously, I mean, women have been delivering babies for thousands of years. But when they have issues, it can be really bad. And so it's something that we definitely need to pay attention to.
And when the fetus is developing in the uterus, the arteries, those uterine arteries grow from these tiny little, tiny little thin, narrow, small radius arteries to larger caliber arteries, preparing for the placenta and the baby. It's scary. And we'll learn about that later, but it's in trauma too, penetrating and blunt trauma, tissue injury.
Yep, something very common. Surgery is another big factor. If you have, I know like in my city, we have obviously several hospitals which they can manage those things, but we have a lot of surgery centers, ambulatory surgery centers. I've worked at those facilities before, and when they have a patient on the operating table that starts hemorrhaging, they call 911. That's what they do. I mean, obviously, they're very well versed in ACLS and how to manage those patients, but they call us to transport them.
To get them to some blood.
For sure. Right. So it's important to know if you have those and be prepared to respond to those emergencies.
And then medical, GI bleeds, great vessel diseases, even medications and tumors. But these are other causes of hemorrhage. That's another category. And we've got all sorts of other lectures you can watch on GI bleeds and some of those great vessel injuries.
Yeah, but sometimes, again, you go on that medical patient and complaining of stomach pain, and you're not thinking life-threatening hemorrhage.
No.
Right? And so that's why it's important to educate yourself on how to identify
And later in this lecture, we're going to get to some of those signs you might pick up on physical exams. Right. Like, whoa, I was going down that path, but this looks like he's got, whatever.
Yeah, which, like we say all the time, is very important not to put the blinders on. So there's different stages of shock.
Right.
And it's important that we know those stages and can quickly identify those stages. So stage 1?
Well, unfortunately, you're not going to notice anything.
That's right.
The patient's going to have normal vitals, and the reason for that is that those big capacitance vessels where we store a lot of our blood in our legs, they've just vasoconstricted with some of that smooth muscle, basically decreasing the whole vascular volume of space. So we're able to compensate, and the heart sees the same amount of blood, the same preload. So we really don't have any reason to change our vital signs because it's more of a vasoconstriction compensation initially. Right. But eventually you're going to max out your vasoconstriction. And so the next step, which is the first noticeable step, is
your heart rate.
Heart rate.
Yeah, and if you think, for our firefighter friends out there, you think about your pump on your engine, right? When you need more pressure, what do? You turn your throttle up on your engine, it increases your RPMs, and you get greater pressure. And that's what we're dealing here. Now, one of the things to think about, and we kind of talked about this while we were going over this lecture, is if you have somebody that has sustained a major trauma, whatever the trauma is, their heart rate's probably already going to be elevated because of the emotional traumatic
Right.
event.
I just got bit by a shark.
Yeah, exactly. You're probably not
saw
gonna...
a shark.
Yeah,
It's gonna go
exactly.
crazy.
My heart rate's at 250. So look at that and take that into consideration when you arrive on scene. You know, you put your SpO2 probe on their finger, or you palpate a pulse, and you're like, oh my gosh, their heart rate's just ticking away. That might not necessarily mean that they're having a massive hemorrhagic shock issue. So take that into consideration initially and kind of look at it. And then, 5 minutes later, after you've, done some management things and tried to calm the patient down, if their heart rate has gone down, maybe you're in a good spot. If it has continued to increase, now you might be thinking, oh, we're heading down that shock, different stages of shock.
And you bring up a good point, because the mechanism of injury might be such that, you learn later in our light board that a femoral artery injury, you have seconds. So you don't need to wait for the heart rate to change. It's like, put that tourniquet on or two. And
if you see massive bleeding out of the legs,
a lot of red water out there or something, whatever.
For sure.
And then the last thing is, eventually you turn up the RPM so high that you kind of get to your limit, and you start to cavitate the pump. Right. So now we've kind of maxed out our compensatory RPMs, and now blood pressure is starting to fall.
That's right. And the number one organ that's going to feel that, and you're going to really see those changes, is your brain. It's so oxygen, it needs that oxygen, that
Very
glucose
sensitive
to survive. And when it gets, even a little bit off, that's when you get altered mental status. And so if you have a patient that you suspect is suffering from a hemorrhage and they're getting altered, you need to be paying attention.
I had a GI bleed patient that I was evaluating in the ER, and then when I went to assess the patient, he looked really sick. He looked terrible. I knew he was sick, but then when he started asking me, like he was ordering food, like he thought he was in a restaurant. He was so altered. He literally thought he was in a restaurant. He was so altered.
That's a little scary.
Could have been some alcohol involved too, but he was very altered.
Yeah.
And that low blood pressure, your brain can't function. That's a big sign that you've gone down the stages of hemorrhagic shock to where the mortality rate starts to climb. Yeah. We got to get blood quick.
Yeah, that's scary. And, I'm a big fan of down and dirty stuff, out in the field as paramedics or flight nurses, EMTs. We don't have all the labs and different things that he has the access to in the ER. So I like down and dirty stuff. And so if you think about a shock index, a real down and dirty way to do that is take your heart rate divided by your systolic blood pressure. And if that number is 1, just for generalities, or higher, that's a pretty good indicator that your patient's in a pretty severe state of shock. Or getting there quickly, and you need to address that.
Heart rate's 140, blood pressure's 100.
Don't ask me to do that math. But I'm
sure
that's
top number's bigger than the bottom.
Yeah,
number.
there you go.
Math.
Yeah, that's a simple way to look at it for sure.
That's good math. I love it.
All right, so hemostatic response to massive blood loss.
Yes.
What happens?
Yeah, what does the body do? Well, the first thing that happens is those blood vessels can spasm. They can constrict, which can minimize some of the blood flow from that injury.
That's right. And then second, you get your coagulation cascade, right? Yep. We learn about this in A&P class and EMT school all the way through. We learn how this happens in the body.
Lots of interesting proteins made by the liver that help to coagulate the blood. But it all starts, though, with a platelet plug.
That's right.
So those platelets actually will detect, and there's a bunch of factors involved in this process, but when they see something other than the inside of a blood vessel, that endothelial lining like Teflon, anything else, any tissue causes a trigger to get sticky and make a platelet plug. And that helps to minimize blood loss. But if it's a massive injury, this isn't going to do much good here. This is just some of the hemostatic responses.
Yeah, if somebody has a severed femoral artery, you're not going to get a platelet plug big enough to plug that hole.
That being said, the patient I had that got his arm ripped off, I was imagining a Monty Python squirting out the shoulder.
Yeah, sure.
There's no blood at all.
Well,
and he wasn't
it was
hurting.
Like pulled, right?
Pulled out of a conveyor belt injury,
action.
high velocity conveyor belt, ripped his arm off at the shoulder. He came in with his arm in a bag, and he was in no pain, and there was no bleeding. It was interesting. Anyway,
that's crazy.
Terrible injury.
Yep. All right, so platelet plugs, you talked about that, can stop
Minor
minor hemorrhage. Yeah, not major hemorrhage. Yep. How fast can we lose blood?
Very fast if it's a big vessel. And we're going to talk about that next. Yeah, very fast. What are the factors? So blood vessel diameter we'll talk about.
Yep.
Is the biggest factor, and we'll explain why.
Yep.
Cardiac output.
That's another factor. Yep. And then we talked about this several times. This is the big one. If you have somebody that has an injury to that femoral artery, again, for our firefighters, think your LDH, your big 5-inch hose, you can lose a lot of volume out of those hoses really, really quick.
Really fast. So immediate recognition, again, that's the key. And that's the cool part of Keen and learning about his story is to hear firsthand how a quick response saved his life.
Yes, for sure.
All right, let's go to the light board, man.
All right.
You know, it's interesting. When we in the past have studied IV flow rates, we talked a little bit about how fluids flow through a tube, much like water through a hose, or blood through a blood vessel, IV fluid through an IV catheter or IV tubing. The same physics that dictate how fast fluids flow have a lot to do with hemorrhage and have a lot to do with what we've been talking about with sharks. So we're going to go back and review some things, and we're going to reinforce some things. So let's talk a little bit more about hemorrhage, and I think this is a really cool opportunity to make a connection. I'm going to actually start over here with this equation over here. I know it looks crazy, it's physics, but flow rates are dictated by multiple factors, and these are pretty intuitive. For example, if you increase pressure, you're going to increase the flow. So if I double this quantity is going to double. So if I double pressure, I'm going to double flow. Pi is never going to change, right? But look at radius. If I double the radius, it actually is to the power of 4. So by doubling the radius, I'm going to increase the flow rate 16 times. 2 to the 4th power is 16. Any change in radius is going to have an exponential effect on flow rates. So again, if I double the flow rate, it's going to increase by 16. If I decrease it by half, it's going to decrease 16 times. Now on the bottom of the denominator here, the bigger these numbers get, the smaller the number gets, right? So if I increase viscosity, so in your engine, for example, if you are a driver or you work in the engine, your flow rates are going to go down if you increase viscosity. That makes sense, right? A bigger number on the bottom of a fraction makes the number smaller. So same thing with length. And you may be familiar with the concept of friction loss. The longer the tube, the slower the flow, or the lower the flow, because again, the length is getting bigger, and that's at the bottom here of this equation. But what I really want to focus on right here is this. The radius has got the biggest effect on this. If I was bit in the hand by a shark, and the shark, it's terrible to say, but took my hand off, I'd have my ulnar arteries and my radial arteries as the main arteries bringing blood to my hand. They could be squirting blood, pulsatile flow, and I need to get a tourniquet on my arm so I don't lose too much blood. But if I didn't have access to a tourniquet, the relatively small arteries here, it's going to take longer to bleed out. What would my flow rates be if I was bit in the femoral artery? What's the difference between a radial artery and a femoral artery? It's a lot bigger than 2 times. So you can imagine, if you're more than doubling the diameter of an artery, how much faster are you going to bleed out? We talked about this concept with IV catheters. If you remember, go back and watch me drill my leg with an IO. You'll learn a lot about this equation with IV flow rates through tubing, through catheters that we use to resuscitate patients. An 18 gauge is going to deliver fluids a lot faster than a 22 gauge. And it's all about radius. It's all about this equation. This is a really cool connection to make. You don't need to know this equation necessarily, but understand the concepts. It dictates flow rates of fluid into the body. It dictates hemorrhage of blood leaving the body. It also dictates some of the way the body moves blood around to organs. When we want to increase our pressure or change blood pressure in the body, we change the diameter of tubes with a smooth muscle on our arteries. It's pretty amazing what's happening in this equation. Now, let's move over now to our stages of shock. And keep in mind, the bigger the blood vessel, the faster these stages happen because of flow rates. Faster blood flow, faster you progress through these stages. So let's briefly talk about this. I'm going to simplify this chart big time. I've left out some categories like pulse pressure and respiratory rate. They're important, but I think these are the key ones here. So if I lose a percentage of my blood, so here would be less than 15%. Here would be 15 to 30%. Here would be 30 to 40%. And then here would be greater than 40%. I hope I did that right, but the point is, the more blood we lose, things start changing. Nothing really happens with blood pressure, mental status, heart rate with less than 15 because our body is able to do this. Vasoconstrict blood vessels and compensate without any changes to vitals. But if we lose enough fluid where this is no longer helping us maintain blood pressure, we increase the heart rate. No change with blood pressure yet, no change with mental status. Why is it true that there's no mental status change as we progress here? It's because the blood pressure didn't change. In theory, we can maintain perfusion of the brain as long as we don't lose too much blood. As long as we can compensate, mental status doesn't change. Well, things get crazy here. Now our heart rate's maxed out and we start to see decreased blood pressure. And then here, of course, we really increase and now we're really decreased. Now we're in big trouble. So over here, we have altered mental status. This is key. The first thing that changes when we lose blood is the heart rate. Then blood pressure starts to suffer, so then we get altered mental status. Here it is in a nutshell, folks. This hypovolemic stage shock graph, or whatever you've seen in your textbooks, and you've even heard me teach it in lecture, I just wanted to boil it down. First thing that changes is heart rate to compensate. When we can't compensate anymore, we can't maintain our blood pressure. And if you can't maintain blood pressure, you start to see organs fail, or at least not function properly. And that's what's happening here. The brain is not getting enough blood, we become altered. You get a patient bit by a shark that's altered and hypotensive and tachycardic, you know they're pretty far down the stages of shock. You get somebody with an injury and they're bleeding and you notice that their heart rate's elevated but blood pressure's normal, they're probably at the beginning of the stages of shock. Knowing these stages of shock can help you with your patients. Before we sign off and go back to the studio, I want to mention one more thing about this chart and about blood loss. Not necessarily about sharks, but anytime you're dealing with somebody in a trauma situation, anytime you're dealing with somebody where you're suspicious of blood loss, like a GI bleed or maybe an obstetric emergency or whatever it might be, remember to ask your patient if they're on a beta blocker. What does a beta blocker do? Well, a beta blocker is going to act on the heart to slow the heart rate down. If you have a patient on a beta blocker, it's going to impact this tremendously. You're going to hamper the heart's ability to compensate because they're on a beta blocker, and you actually may hasten the organ dysfunction at a lower level of blood loss. Bottom line, a patient on a beta blocker may have less time to survive before they start getting symptomatic because of the blockade of heart rate and their inability to compensate. Something to keep in mind anytime you have a patient with any blood loss on a beta blocker, be very careful. You may not want to trust the heart rate. Be starting to think about mental status if somebody's on the beta blocker. Hey, I hope this helps. I hope you understood. I hope you learned something new. We're going to go back to the studio, continue to learn about hemorrhage and these crazy sharks.
There's very little evidence that sharks prey on people. There's very few cases where flesh has been removed and consumed. In most cases, people are bitten and released. So again, this is why we believe humans aren't on the menu when it comes to sharks, but accidents do occur. And whether they're defending themselves or whether they're biting people because they mistaked a hand or a foot for prey, we don't know the motivation prior to those bites, but those are the two most likely explanations.
Dr. Lowe, that dude's, he knows his stuff about sharks for sure.
Yeah, and so we manage shark bites and things like that based on what we've learned on the battlefield.
Yeah, that's where we kind of got our feet wet, so to speak, when it comes to hemorrhage.
Oh, that's funny. Yeah, so most of the time on a battlefield, fatalities are going to be from hemorrhage, 91% of the time.
And I think actually we should change that. It's not from battlefield, it's from like hemorrhage and trauma. That most of the time, what kills people in trauma is hemorrhaging.
Yes,
right?
true.
From a battlefield to an NBA, those
correct.
kind of things, shark bites.
Yep.
Yeah.
And I think where I got this data, you can check it in the references, we're just looking at battlefield data,
right.
But the same is true, you're right. I mean, you're getting major trauma, what you're going to die from is whether it's internal bleeding from blunt trauma or a severed limb, you're going to die from hemorrhage 91% of the time.
Yep.
Airway obstruction.
Yep.
Jinx. Is smaller amount of time, but it is significant though, and that's part of the whole March approach, right? Major hemorrhage first, but then airway
is second. That's right. That's
which would include breathing,
tension pneumos, especially in your
pneumothorax.
Blunt patients. Yep, you want to be mindful of that and treat that appropriately if needle decompression or whatever your local protocols are to handle those kind of patients.
We'll get to it in management more, but really taking care of that hemorrhage first. That's the whole history here. That's what we've learned from battlefield medicine.
That's right, and it doesn't matter. Like any level of provider, pretty much can treat hemorrhaging. Right. Pressure, tourniquets, and we'll get all into that during the management. So, locations. Where do people bleed the most?
Yep. Torso.
Yeah, which is bad for us.
It is.
Them.
Well, it's bad. Yeah, you're right. Yeah. And what makes this particularly difficult is that
words are hard.
Words are hard. I'm hooked on phonics. Is that the chest and abdominal cavities, when you're bleeding in there, some of those sources and problems can't be fixed in an ambulance on scene.
Yeah, you can't put a tourniquet.
Yeah, your spleen is ripped apart from a seatbelt.
Yeah.
It's kind of hard to fix that in the back of an ambulance.
Pretty hospital.
But you can get it to a trauma surgeon who can get that taken care of and manage that.
That's
so that's why it's so important to transport quickly. But there may be another type of an injury.
Yeah.
So junctional
injuries. Yep. You have those to the junctional shoulders, hips, groin areas. Those are typically, and again, we'll talk about this more in management, but there's some things we can do pre-hospitally to help control some bleeding.
The tactical team that I support has junctional tourniquets. There are some junctional things that we can do.
Bandages and stuff. Yeah.
But obviously, and then finally the extremity injuries. Those are the tourniquet, type things that we can do. We'll talk about that in Unit 2, but about 13% of the time. So these are the locations where you might bleed from, and it's good to think about that when you're approaching a patient. Is you may not see the bleeding that's happening in the torso, the most common place.
Yes,
right? So,
and you might not think bleeding like we talked about with our OB patients.
But we talked about it with the hemorrhagic shock. You can look at the stages of shock as you're managing a patient, and you see the heart rate going up. You see that shock index starting to occur, and you think, wow, I don't see any. Oh, the torso. Maybe we're bleeding in the belly. Exam, firm abdomen. We'll talk about this as we get on to assessment.
Well, let's hear more of Keen's story. The continuation of the amazing Keen Hayes and his story.
Well, he's not bit yet, right? Yeah. So he's just getting out in the water. Let's hear what he has to say.
Got my fins on, got my snorkel on, was just kind of putting around, looking around, and then started getting closer out to the outside of, like where the surf starts to stop breaking and where the reef starts. Was looking around in the reef grass, didn't really know what I was doing, didn't know how to really snorkel or hold my breath more than 10 seconds. So I was just going, messing around. It's probably 6:30 in the water. At that time it was like 6:30 a.m. Was in there for another 20 minutes, was just barely getting out past the surf, and I started seeing like these little like holes of reef. So there's There's like the top of the reef, because it's all rock reef, and that's all covered in the grass. And then the current would come, and then as it goes back, there'd be these little holes with like sand in them. And I saw this one big one, and I kind of knew what I was looking for. I knew they had the antennas, and it had this big kind of shelf over it. It was about probably 9-10 foot deep. I was like, okay, I'll just go check it out.
So Matt, this is why we're talking to Keen. I mean, we're what we do in managing a patient like Keen, whether it's a shark attack or an MVC or a chainsaw accident, we've really learned from the military, as we talked in our last section, and really we've put it into this MARCH acronym.
Yeah.
Right? MARCH is really this is the way we approach a trauma patient, right?
Correct. Well, this is the way everybody should approach a trauma patient. That's
Massive hemorrhage. So you got to recognize massive hemorrhage first and address that before you move on.
Yeah, these are in order of importance.
Correct.
So as you know, if you're not familiar with the MARCH acronym, these are the things you need to pay attention to in order. So you said
Correct.
Massive hemorrhage, which that's obviously what we've been talking about all day here.
And then airway, which is a very important thing. But again, if you bleed out, there's really no airway.
That's right.
You don't need an airway for your own blood.
There's nothing to carry the oxygen with, so you got to keep that in.
I'm sorry. We'll talk before we get to respirations. We'll talk about this later in Unit 2. But there was a patient we had that was actually a near drowning because the shark drove her down.
Yep.
And even though she needed to be intubated, it was the 3 tourniquets that really saved her life. Right. So anyway, we'll get to that one next unit.
If you start breathing, you control an airway, or you're giving respirations to a patient without any blood, that does nothing. They have to have volume in the system in order to circulate the blood. So
MAR.
Respirations, yep. And then we got circulation. Obviously, don't forget C-spine with these patients. Obviously, especially a shark bite victim, in Unit 2, we're going to see some pretty dramatic pictures, but you can really get honed in on some of these massive injuries and forget to be holding C-spine, right?
Yeah.
That's a big thing that we need to be paying attention to.
And then head injury and hypothermia.
That's right. That's another big thing, especially with these patients in the water that are wet. We need to make sure that they're warm. Us here in Texas, I preach about this all the time when I'm teaching, because it's easy to forget, because in summertime in Texas, it's 100+ degrees. We're working hard trying to help our patients. A lot of our firemen are big guys. They're hot-natured, so they're already sweating and hot. And then we got our ACs cranking in the back, and we've cut all the clothes off of these patients, and meanwhile, they're dying of hypothermia.
And that is, again, we're not going to get into this here. We've talked about it many times in other trauma lectures, but that triad of death, is hypothermia is part of that.
Yeah.
So that's the approach for a hemorrhagic injury, but what are we going to see?
Some signs and symptoms, right? We talked about this a little bit earlier with our stages of shock. We're going to see tachycardia initially, and take that into consideration with the trauma that they've experienced.
And then if you eventually you can't compensate, so right now we're starting to get hypotensive, maybe moving down that spectrum of shock, hemorrhagic shock.
Losing that volume.
Maybe stage 3.
Yep. And then you're going to see that parlor and cold extremities, right? Because you have no blood.
Parlor? Like a
parlor?
Parlor?
Yeah, isn't that how you say it?
Pallor, right? Pallor. I thought you had an R.
I did say
parlor. I don't know what that is. No, yeah.
It's called my eyes are playing tricks on me.
Well, Dr. Schwartz actually talked about this. He said one of the common things, and I've seen this in the ER, I'm sure you've seen it too, is that you get this massive blood loss. The patients all look gray.
Yeah, I remember, in the video, him talking about that.
Very parlor.
Yep, very parlor. Parlor patients are bad.
Eventually, though, the brain, like you said earlier,
they start saying weird words.
Weird words, yeah. Order a sandwich from you instead of
no kidding, right?
Altered mental status. The brain's not getting the blood it needs.
And you got to consider too, is this, because we talked about it with MARCH, is that because, are they altered because of head injury, or are they altered because of hemorrhage? That's where it's really good to do a proper assessment.
I would advise in that, as we talk about assessment, is you're think about the worst thing it could be. This altered woman comes in, family thinks it's a UTI, and I'm like, well, okay, that maybe it is, but I'm getting the CT. Sure enough, subarachnoid hemorrhage or whatever it is.
Yep. Yeah. Decreased urine output, not really something that we're going to notice pre-hospitally, but it's something for folks that if you have access to those kind of things, you could look for that.
Correct. diagnostic tools, really your brain, between your ears, the situational awareness, right? Like how close is your understanding of the situation to the reality of what's happened to this patient? If we've underestimated the mechanism, or if we don't have a full appreciation for the patient's medical history, we really got to get a good history. We got to really get all those signs from our physical exam, so our situational awareness, our understanding of the situation is as close to the reality as possible.
That's right. And vital sign monitoring, we keep talking about that. You can't just get one set of vital signs. This, obviously, with a major hemorrhage patient, you are trending your vitals every 5 minutes.
Right.
You are double checking that blood pressure, that heart rate, all those things.
And you're checking on the mental status, too. With your physical exam, you're constantly like, man, they're starting to act kind of funny.
Yeah.
Or, whatever it is.
Yeah.
Well, speaking of physical exam, what other tips and tricks can we
Well, you
discuss?
talked about this earlier, the conjunctiva, where you get those ugly-looking... How did you say it?
Conjunctiva. Oh, pallor.
Pallor look in their conjunctiva, all those big doctor words.
Well, you can see it on the screen. On the right, you can see the pale conjunctiva. And,
That's right.
and next time you have a patient that's lost a lot of blood or could be anemic, check it out. You'll see it. It's actually pretty profound. It's a great way to assess their blood volume.
Yep. And then you got the normal, right? The skin creases, the palm skin creases.
I don't know if it comes up on camera, but we can see our skin creases, and where the skin creases are, the skin's a bit thinner and the blood shines through. If I had a lot of pallor here and I didn't have a lot of that blood, I'd lose the skin creases. That's another little tool that we can use.
Interesting. And you get your oral mucosa. Looking at the
my tongue, hopefully it's kind of pink, right?
Yeah, I hope so.
But if again, you can see it on the screen. You got an example of some pallor in the mucosa of the mouth, another window into the blood status of your patient.
And then finally, we got our nail beds.
Yeah, the nail beds, Do you look at your
crucial.
fingernails like this, or do you do that?
I don't really know.
I think that women kind of tend to do this, and men kind of tend.
Well, then I do it like this for sure. I have no idea.
I saw you doing
Never
that.
consciously went, oh, look at my nails today.
You can see on the screen, though, on the left, you got some pink to the nail bed there. That's the blood, obviously, in the nail bed. And then on the right, you can see it's very pale, very white.
Right.
And that's a sign. Again, you can use the hands, very useful for assessing that. In the face, the mouth, the eyes.
Yep.
These are physical exam tricks that you should use when you're assessing your trauma
And
patient.
don't forget about cap refill. Press down the head of that fingernail and see how quickly you get the return. If it's less than 2 or 3 seconds, you're good. If it's delayed, that should be...
And when you get that modeling to the skin, again, not on the screen, but another tip is that you get that modeling, and you put your thumb and you lift your thumb off. It's still pale there. See, initially it's pale, but then my blood kind of refills that area.
That's right.
If that doesn't happen quickly, you could be in deep weeds.
So now we're going to you and Dr. Schwartz.
Oh man.
And out in the ocean.
I was trying to forget about that, but yeah.
Well, it's over now. It's good. You might as well,
But it's like PTSD. Like it really was scary. But when we were out there, though, Dr. Schwartz and I, he has some surfboards. We went out there on the water, and the idea was to go swim out there in this shark nursery where these people were killed. And I thought it sounded like a great idea at the time, but then,
as you're sitting there for an hour, waiting on Devin to get his stuff together on the beach.
Yeah, he's playing around with the drone. We're trying to coordinate drone shots back and forth.
Sipping
with the
Starbucks.
drone.
Hang on, I'll be right with you.
Anyway, so the purpose of all of this was to get some great shots. And the Shark Lab was amazing with Dr. Lowe. He gave us some great pictures and shots, which we couldn't have gotten on our own. We got some great shots too. Now here's this shot is the scariest of all the shots. This is absolutely nuts. That this shot was taken. But all in all, the reason we did all this was to really bring hemorrhage to life, create something that people are going to want to watch, and that's why we did all this crazy stuff.
The people that have been bit, their faces are really this weird pale gray. It's this ghost-like gray that's very recognizable, and that just tells you they've lost almost 40% of their blood volume.
And I suppose when you see the injury too, with all the blood in the water, I mean, 1 + 1 = 2, right?
Yeah,
Get
yeah.
the tourniquet on.
Yeah,
if you can.
You never know how much they lost, but as we've described before, you have to look at the vital signs and the mental status.
Yep.
And if the wound's not bleeding, that's a little concerning sometimes.
Dr. Schwartz was right on. I mean, you can see the gray, ashen face, but that's just one of the assessment tools we learned about. But before we get to the management of these emergencies, we got a few more hemorrhage pearls to cover.
That's right, and we talked about it right from the beginning of this lecture, that early recognition of a patient suffering a life-threatening hemorrhage is absolutely crucial. There's no way that you can treat or help your patients if you don't recognize that they're bleeding. So that's very, very crucial.
Well, that first term before we get to maintaining perfusion it's actually more complicated than you might first think. It's really two things. It's early, like quick, right? You got to be quick.
Yep.
And then recognition is the assessment of things, right? And knowing what to look for.
Quick and accurate?
Quick and accurate. Yeah, quick. I mean, that's a big deal. That's really, if there was one pearl from this lecture, that's really the crux of all of it, is quick recognition of the emergency.
Yeah, absolutely.
And then we'll talk about what to do in the next unit.
And I would even say, and we'll talk a little bit more about this management-wise, but I would even say that once you recognize that you're dealing with a hemorrhagic patient, you need to be thinking very quickly about getting to the hospital or calling for an advanced level of care. If you're calling for, helicopter because you're in a rural area, something like that, you need to be thinking about that really, really quick, because we cannot really fix these patients on scene. So,
and that's why it's early recognition, because to maintain perfusion, point two, / blood pressure, you've got to stop the bleeding. By recognizing it early, get the tourniquet on early, you don't lose a ton of blood.
That's
right? Or if there's some delayed assessment and delayed, oh crap, I didn't notice the pale conjunctiva.
Right.
Crap, we got to get out of here. This guy's bleeding.
That's right.
Those, again, the goal of early recognition is to maintain perfusion.
That's right.
Because blood pressure is what keeps our organs alive, and that's what's killing these people with hemorrhagic shock.
That's exactly right. And along with that blood pressure, we have to talk about permissive hypotension.
Yes.
So, for our paramedics out there, a lot of us sometimes get caught up in, well, I want a blood pressure of 120/80. Well, that's not probably going to be realistic in a massive trauma situation. And you have a trauma surgeon friend of yours that said one time something about he's happy with a blood pressure of 70 or something like that.
Right, exactly. Instead of giving those fluids with a low blood pressure, he'd rather have a blood pressure of 70/40, he said. Right. Now, this is anecdotal. The goal is really 80 to 90.
Right.
And we've talked about this before. By giving fluids, we increase the leakiness of blood vessels. We dilute the blood, decreasing its coagulative potential.
Yep.
Permissive hypotension is a real big deal.
Yep.
If we were together in the back of an ambulance, and when we are, it's always fun. Assessing the mental status is so important.
Yeah.
Because you see a blood pressure of 85/40. What do we really do? We talk to the patient. Hey, sir, how you feeling?
That's
Well,
right.
I'm feeling a little bit lightheaded.
Yeah.
Okay, well, that's a little more concerning than I feel fine. Why are you asking?
Right.
It's like, okay, well, let's
And
just...
I'm double checking the blood pressure to make sure that the machine read it right.
And maybe get a manual or something.
Yeah, exactly. But so, if you have IV fluids, give a little bit of fluid. Again, we're not doing like we did 20 years ago, where 2 large bore IVs and then 2 bags of saline or LR and just dumping the fluid in them. If you have blood products, absolutely, this is where you would be giving your blood products. You're replacing what they lost, right?
Can I add something here just real quick? I'm kind of getting into management a little bit, but I just wanted to say this, is as we talk about permissive hypotension, a recent story, actually, we talked about this, I think, is we've been giving TXA in our municipality with a liter of fluid because there's a shortage of 500cc bags, and so we changed the protocols just recently to put our TXA into 100cc bag to minimize the fluid that we give. Even if it's over 10 minutes, right, giving our TXA in our protocols, minimizing fluid is a big deal.
Yes.
So I think we're going to get to that more in management again, but for now, just to talk about permissive hypotension, we can
you don't
tolerate
need
a little more.
You don't need a blood pressure even over 100 in these situations. No. If you're at 80 to 100, man, you're doing great. So just keep that in mind.
And I think everybody's protocols might be a little bit different, but the point is permissive hypotension. It's okay to be a little lower than normal.
And then your airway emergencies, and again, part of that March trauma assessment, massive hemorrhaging, and then airway next, right? You want to make sure that they've got enough volume in the tank, and then you want to make sure that they have enough oxygen to be circulated with that volume.
And I think the thing to keep in mind is that the brain is what protects your airway, right? Your brain is receiving signals from your autonomic nervous system to cough or choke or whatever. When you start to deplete the brain of blood in a massive hemorrhage situation, the brain's not functioning, and now we may not be protecting our airway properly. That's where the airway emergencies can arise, and that's why it's important to be aware of that. So as a paramedic, you may actually be thinking about taking the airway potentially, being prepared, getting set up, having everything at the at the ready, and making sure you're prepared with your backup airway adjuncts or whatever you might need. And giving a little bit of oxygen too can help to increase your oxygen carrying capacity to maybe prolong the time.
That's right.
Get them
we'll
to the
talk
ER.
a lot more about that in the management section.
Management,
we'll go way more into depth about that. So next we're talking to Keen again. We get the continuation of Keen's story.
Yeah, so Keen, the last time we left off, was in the water and diving down,
for lobsters.
Looking for lobsters. And now this is kind of this is where things get scary.
This is the moment almost.
And so after this installment of this video, we're going to close it out after that, get some summary, and get on to Unit 2. Definitely stay tuned. Watch Unit 2 where we get into management. But for now, let's go back to Keen.
Come up to the reef. It's like directly underneath me. Do like a quick little dive, and I'm looking under this little shelf that was there, and I was grabbing onto some rocks, and I was like, okay, there's nothing here. I'll just go up and keep swimming. Just completely normal. Didn't think anything of it. And I'm coming up, kicking a little bit, and I put my hand up because I was starting to get really out of breath, so I wanted to just do like one big, just get me out of the water as close as I can, because I had no freediving experience before that. And it just felt like a huge, just like Troy Polamalu or something like that, just tackled me out of thin air, just like completely hit me. I felt like some pressure, and I kind of like squeezed a little bit, closed my eyes, and I just felt like pressure all along my side. No pain, just like pressure, and I felt like a little shake, and then it just kind of fell over.
Getting hit by Polamalu would be scary enough.
Yeah.
That would be terrifying enough, getting hit by that dude. But
well,
I think
story. It is an exciting story, and it's the interesting thing is this really happened. We're talking to the victim, and we're going to carry this story on into Unit 2 as well.
That's right.
But so let's close out our first unit. Again, assessment. This is really good. We first started off, we talked about how deadly these hemorrhagic traumas can be.
That's right. And then we talked about different stages of shock, which we went over that.
Important to understand that.
Very
because
much.
That's going to reflect what we see in signs and symptoms. Again, factors that increase the rate of blood loss are going to affect those signs and symptoms.
That's right. And then, signs and symptoms of massive blood loss, what to look for. These are all combined things that you want to look for and identify in your hemorrhagic patients. Very important to do that. So stay tuned for Unit 2. We get the continuation of Keen's story. We're going to go way more into management of these patients, how to handle these patients. So we'll have a lot of really good cases.
But before you do that, we got assessment questions here for Unit 1. Take your assessment questions.
That's right. We'll see you guys in Unit 2.
Be safe out there.
And the swimmers swim, beyond the surf break, so they're more in the water where most of the sharks are. A lot of the sharks are not in the waves.
Kind of like where we were.
Yes.
Okay, keep going.
This course will include detailed discussions, injuries, and anatomical structures that may be graphic or disturbing to some viewers.
When you're comparing a bite from an animal to a grenade, you know you're dealing with a big animal.
Yeah.
Is it a great white that did
Yeah,
it?
these are all great whites that
these
hit
are all-
people
okay,
here. That's
okay.
the great whites, as you've heard or will hear are kind of living in this area as a nursery, where they come, the babies get dropped off, they raise themselves for 3 years,
Okay.
they grow to about 8 feet, and rarely, but sometimes they'll get confused as to thinking we're a seal.
So nursery.
Yeah.
This is more information I didn't know. So I'm glad you're
Again,
telling me that now.
I held it back from you. You're committed.
Dr. Schwartz is a crazy man.
You're a crazy man. You were out there with him.
Right, and we had a great first hour. Hopefully you watched the first hour, first unit on assessment and the international sign of a shark in the water, which may or may not be on the assessment.
That's right.
So that's we learned a lot in that first unit. Which
That's
was
right.
Good.
And we got the intro into Keen Hayes' story.
Yeah.
And we're going to have the continuation of that.
We will.
Over this next hour. We're going to hear kind of after his incident. And
First unit, we went from, the meeting Keen to getting bit, getting struck by Troy Polamalu.
Yeah.
And now we're going to go from getting bit to treatment.
That's
so
right.
it's going to be really good. I'm excited to share the next hour with you.
Very exciting. Well, my name's Matt Ball. I'm a firefighter paramedic, registered nurse here in the Dallas area.
My name's Eric Exene. I'm an ER doctor and EMS medical director.
We got some more shark facts.
Yeah, there's a couple things. So most fatalities are due to great whites. They're really, if you think shark bite death, it's great whites.
That makes sense.
Yeah, the other sharks will, maybe take a limb or, maim you, but the ones who die are usually the great whites. They're just so big and
It's
so
like getting hit
devastating.
by a bus with teeth.
Yeah. Yeah, like we learned in the first unit. I mean, these things attack with 2-inch long daggers, 5 rows of them. Actually, I think it might not be 5 rows, though.
Yeah.
Is it
It's 5 rows. Yeah.
Well,
Or that's
a lot of teeth.
Yes, a
Doesn't
lot.
really
Yeah.
matter.
Too scary.
4,000 psi bite. Yeah. Now, most unprovoked non-fatal bites occur in the U.S., like we learned before.
Right.
And most of them are not fatal. But and you can see with the great whites, 292 bites, 59 fatalities. Tiger sharks, 103, 39. And then the bull shark,
The big bull,
93 and 26.
All of which, what did Dr. Lowe call those, the big three?
The big three, yes.
Yeah.
These are the big three.
Yeah, those are big, terrifying animals.
We were really lucky to have Dr. Lowe participate with us.
Yes.
Dr.
Oh, for
Lowe,
sure.
World expert on this. Again, in Unit 1, it was amazing.
Yep.
So what are our objectives, Matt?
Well, first we're going to list different approaches to the management of major hemorrhage.
Yep. And then we're also going to outline the management of a patient with major hemorrhage.
That's right. And then we're going to apply the understanding of major hemorrhage to patient scenarios, go through some cases.
We will be going through 3 different cases.
Absolutely.
And we'll practice what we learn. Well, the first thing we're going to learn, tourniquet anatomy.
Yeah.
Tourniquet is a French word. I think you looked this up.
I did. I didn't know this. Did you know this?
I did not. I took French in high school.
Oh, did you really?
4 years of French.
Parlez-vous français?
Oui, oui.
I don't have to go to the bathroom. Oh, I got you. No, yes,
Je suis
tourniquet.
désolé, mi bâton.
I have, what is it? No, that's something else. I can't say those words because for our French friends, they might think I'm saying bad words. But anyway, so tourniquet back in, I believe it was the 1600s. It was, like we talked about in section 1, a lot of our knowledge on treating trauma patients came from the battlefield. And that's where a tourniquet came from, was a French, I think he was a surgeon with some French military organization. Before that, the surgeons and stuff would just use just whatever they could get and tie it tight.
Twist.
But then he figured out the twisting motion of it. And then I don't remember the guy's name. But tourniquet is basically the French word to turn.
To turn, right?
Yeah, that's kind of where it comes from.
Sounds like it, too.
Yeah,
Turn,
absolutely.
tourniquet.
And so we got, exactly. Tourniquet.
Where did the word windlass come from?
I don't know where windlass rod came from or windlass clip.
But you can see, though, that the windlass rod is really what gives you that mechanical advantage.
That's right.
In creating the kind of pressure you need to occlude an artery
That's
in
right.
that limb.
And the windlass clip, obviously, is what
gonna
that rod sits
stabilize
in. And those two pieces are why, for everybody out there, if you are purchasing a tourniquet, Be sure to get approved cat-style tourniquets. Don't buy that junk on Amazon. Sorry, Amazon, but don't buy that junk from foreign countries that's not made well. And this is the reason why, is because when you go to crank those down, you have to put, those are under a lot of tension, those rods and those clips, and those fail. And that's why we don't want to use those. So,
and on a side note, at the Boston bombing we had not too long ago, a lot of improvised tourniquets were being used.
Sure.
Problem with an extension cord is they're so narrow, you don't get that footprint like a tourniquet does. So this may or may not be an assessment question, but what's really important is to use a actual approved tourniquet when in an emergency. You don't want to mess around with improvised tourniquets. Obviously, if that's all you got, that's all you got. But we, as providers, should be prepared with the best equipment possible.
Yeah, we should absolutely have that. So we got the windlass rod, the windlass clip. You've got the self-adhering strap.
That's just to secure it, to make, just to really secure it. And oftentimes on that self-adhering strap, there's also a place to write the time.
That's right. Yeah, it's usually over the part that goes over the windlass clip, actually.
I'm sorry, that's correct.
Yeah, it's got that little timestamp on it. And then you got your buckle, obviously, that it slides through. And then you got your retention strap.
Yeah, that's for the
yeah, that's what you were thinking of. Yeah, and a lot of times, then we'll kind of go over a little bit of tourniquet application. But if you're doing it on yourself, that strap, you should always have it pulling towards you as opposed to away from you. You can get more force pulling it towards you.
That's smart. Yeah, if you're applying it to yourself.
That's right. So, tourniquet indications. When do we put on the tourniquet? Yep.
Massive arterial bleeding associated with extremity trauma.
That's right. I don't love, but sometimes you come across these videos on social media or YouTube or something, and love our police officers out there, and they're doing a great job. They're figuring it out. But anytime anybody gets the slightest cut, boy, they're reaching for those tourniquets. They are throwing tourniquets on for everything. And, really, it's as medical providers, right? Yeah. We need to know what arterial bleeding looks like, right? If you just have a venous bleed, if it's slow bleeding, something like that, that doesn't need a tourniquet. Remember that you can always apply pressure first. If that stops the bleeding, you don't need to put a tourniquet on. But if I walk up and I'm seeing squirting
pulsatile flow of bright red blood.
Bright red blood, yeah.
Venous blood is
slow, dark.
Venous.
That's like parlor.
Venous blood, venous, whatever.
Venous?
Is
you say
gonna
alveoli
be a
or
darker
alveoli?
Alveoli. What do you say?
I say ravioli.
Ravioli.
I'm just kidding.
Duodenum. There's so many.
There's so many. Latin. What a silly language.
But arterial blood is pulsatile and bright red. Venous blood is dark red, and it just oozes. Yeah, it's not pulsatile.
And then bleeding not stopped by pressure, like we said. If you put pressure on it, it's not stopping. It's continuing to bleed. That's when you would go to a tourniquet. Just because they have a wound doesn't mean you automatically need to use it.
I'll tell you right now, if you see a massive amount of blood from an extremity, you're going to need a tourniquet. Get that tourniquet out and ready.
That's right.
Yeah,
that's right.
Right away. So, when we were out there in San Diego, Dr. Schwartz, along with some of the lifeguards that he's worked with, they demonstrated some of the tourniquet placement.
Yeah. We watched this video here. Both these lifeguards actually treated one of the shark bite victims.
And it was actually just days before we were down there in San Diego.
Yeah.
A great white right out in that beach there. So
put
you got that strap, the Velcro strap, and you're gonna get it tight.
Yep.
But then it's that windlass rod that you can see him turning.
That's right.
Turning it.
That's right.
That's what gives you that, like we said, that mechanical advantage, and then securing it.
Checking for the pulse to see. Pulses. That's how do you know if the tourniquet's on good enough, right?
Yep.
You either you lose the pulse down here, or the bleeding stops.
Yep.
Right. If the bleeding stops, that's good. One thing to note too is that he put the tourniquet, a couple inches proximal to the wound, right?
Yeah.
And
based on where he put it, the injury must be close to the wrist.
Exactly.
Right. But I think you and I both teach it differently. We ride high or die. We put that tournament up nice and high, as we can go.
That's right. And that's kind of one of the things, again, follow your local protocols as usual. But I believe in the theory of ride high or die. And a lot of times you taught me this about how those vessels can suck up,
that's
up into the wound. And so if the wound is down here, well, the bleeder might be up here, and if you only go, you might not hit it. And so it's best to go up. Again, these are temporary stop the bleeding measures. Get them to the facility to where they're going to get taken care of and go from there.
And if you do it right, it should be uncomfortable for the patient.
It is going to be painful.
It's going to be tight.
Yes. Yeah. When we first got these in my department and we put them on, those things hurt. So be ready if you have the ability to do pain management.
And I do think we mentioned this later, but usually for a lower extremity, larger blood vessels, it's going to require a couple tourniquets placed above the injury. So ride high or die.
Yep.
And then you tighten with a self-adhering strap like we talked about.
Talked about that. Saw that on the video. Rotate the windlass rod till you don't have the pulse. The bleeding stops. Note the time again, like you said, on that strap. Write the time down, especially if you're in an urban or a rural area where you have an extended transport time. Make sure you put that time on there because that could be a factor.
Right. And injuries actually start happening relatively soon. I mean, I think 6 hours is kind of the industry standard for tourniquet placement.
When we first got tourniquets, they said you could leave them on for up to 48 hours. That's what we were told.
Oh, really?
Oh, yeah.
That's what we were that's when the damage starts, but 6 hours is kind of the...
Right.
Anyway, yeah, so that's a pitfall. Be aware of that.
Yep, that's one pitfall. Don't go over a joint, right? Don't put it on an elbow. Don't put it on a knee, anything like that. You want to go into it. That's right. That's right.
And tissue injury, ischemia, fancy word for lack of blood.
Which that's 6 hours.
Cause reperfusion injuries, right?
That's right. That's right.
I actually did research on this. It was interesting. I was putting tourniquets on rat legs, and we were measuring some of the reperfusion products and the damage that they would cause.
I want to see a rat tourniquet.
Well, it really was just a rubber band.
Oh, rubber band, got it.
But it was really interesting to see that reperfusion injuries are real because when you leave those ischemic areas to fester for a while, the body starts making some toxins for cell death. And then when you release it, it gets released through the body.
Compartment syndrome, crush injuries, kind of similar. Don't forget to document, obviously. Another thing, too, and we were teaching this class yesterday, and one of your tactical medics brought this up, is that another pitfall to remember is pockets. If you're putting this on a leg, make sure there's no cell phones, specifically cell phones, but nothing in their pockets, or else you won't be able to get a good seal on there. So
and then you may want to ask your individual, especially as a male, to rearrange the furniture too. You don't want to put the tourniquet over a testicle or a penis. And if you have an unconscious patient, you want to make sure that you're not putting it over the genitalia.
Right.
Might
you
not
don't
be
want to
good.
cut off circulation to unnecessary areas.
Continue.
All right.
So permissive hypotension, we talked about this in the last unit. We'll hit it again. This is really important.
That's right.
We're not shooting for 120 over 80. It's okay to be 80s or 90s.
Yes. And again, be mindful if you've got a head trauma patient, that might be a little bit different. And we're not going to get into the pathophysiology of head traumas, but those patients, you want to keep their pressure up a little bit. So be cautious of that.
Yeah. Again, for these folks, the goal is to get them in perfusing rhythm somehow to the hospital where they get fixed.
That's right.
Head injuries are different animal, which we talk about. Targeting a normal blood pressure, again, like we said, can make the bleeding worse, and maintaining a systolic 80 to 90. That's the goal.
That's plenty good enough. You don't need 120 over 80 at all.
And we talked about the trauma surgeon. 70 over 40, he's super happy.
That's right. IVIO access, again, start your IVs, get the access. You can still do, again, when I went through school, when you went through, it was 2 large bore IVs and then 2 bags of fluid wide open. Well, the 2 large bore IVs is still a good thing, but we're not pouring the fluid to them. I'm starting the IVs pre-hospitally so that when I get there to this guy, they've got good access that they can do what they have to do.
Big central catheters, cortices.
Yes, they can do that. But IO access, definitely on a hemorrhagic patient, don't go tibia. Follow your local protocols, but I'm going humeral head or I'm going femur if that's allowed in your protocols, because through a tibial IO, you are not going to get a lot of volume through that. So just keep that in mind.
Initial fluid resuscitation with crystalloid as needed, but again, we talked about this before. We want to replace what's lost acutely. Giving IV fluids can actually cause a lot of harm. So if you do it, it's got to be judicious. Follow your protocols. But I know for me, anecdotally speaking from my agencies. We're changing things because we were giving too much fluid with the TXA when we gave it. So we're actually going down to a 100 cc bag just to minimize the fluid administration.
The volume.
We don't want to make those blood vessels leaky, and we don't want to dilute the blood.
That's right. Yep. And that's don't give too much fluid. We just went over that. We've talked about that repeatedly. So if you're still working in a system that's 2 large bore IVs with 2 bags of fluid wide open, you probably need to rethink your protocols. Visit with your medical director about that.
Last section here. So again, we talked about replacing what's lost. Those are blood products.
That's
so
right.
2 main types of blood products. You got packed red blood cells and whole blood.
That's right.
Packed red blood cells, like it says, is just the red blood cells. Yeah. And the plasma's been removed.
That's right.
Whole blood's got all this stuff.
That's what you really want. Yeah, that's the goal, is the whole blood, because it's got everything. And in our critical care lectures, we talk more about the elements of that. But if you're a paramedic that carries blood, good for your agency, that's what they need.
Yep. And so in the hospital, when we have a massive transfusion protocol, it's a number of packed reds and a number of FFP. So it's like you're getting whole blood essentially.
Right. It's a 1-to-1-to-1. Yeah.
But by getting whole blood, you're just getting everything there.
Getting everything that you need in one place. So now we're going into the next section.
Yeah, we're going to start getting into some cases. And then we'll pepper in some concepts and some important things that we need to understand along the way. And we'll continue watching some of Keen as we move through.
Of the Keen story.
Yeah, this is good.
No pain, just like pressure, and I felt like a little shake, and then it just kind of fell over, and I was still a little bit from the surface. It kind of pushed me up a little bit, and I get up. I'm like, oh, that was kind of weird. Like, I have no clue what that was. And my first thought was that it was Noah, the guy I was with, and I thought he came up to me and swam up to me and like grabbed me and shook me and stuff, and I was like, okay, that's really funny, it's my first time, he's just messing with me. And I looked to my left, and he's probably about 10, 15 yards away from me still, and I could see his face was down, his snorkel was up, and I was like, okay, that's kind of weird. And then I just look over to my left side, and there's just wetsuit everywhere, there was blood in the water. I could see my humerus kind of like sticking up like this. I saw part of it, and I just felt like, not like pain, but just like, oh my God, that does not look right. It should not look like that at all.
Well, I think the most important thing that people need to know from a pre-hospital care standpoint is you can have small sharks, you can have big sharks, right? The bigger the shark, usually the bigger the teeth, especially for the large 3, right? And what most people are surprised and shocked by is the magnitude of the injuries. In fact, many ER docs have said they resemble more combat wounds than they do any other type of trauma they've seen.
Well, we're at the beach, obviously, here with Dr. Schwartz. We're going to talk about some cases. We're going to practice what we've learned. Thanks for sharing these cases with me.
You're welcome.
Let's talk a little bit about this first one.
Yeah, this first one's really interesting. This happened around here, right where we're filming, a little further up the beach. She was a 32-year-old female, and she was swimming with her boyfriend who was surfing, and she always did that. She was in a wetsuit. And she saw this very frightened seal jump out of the water and onto the surfboard.
Oh, the seal jumped on the surfboard?
Yes. And then she jumped on the surfboard.
I didn't know that.
No, she jumped on the surfboard with the seal and with her boyfriend. All three are on the surfboard.
I had no idea that happened. That's weird.
And that turns out to be kind of a characteristic. If you see like animals jumping out of the water, sometimes sharks are around. Anyway, so they're up there, and then the seal just slithers off because the water seemed calm and clear. And so she jumps off, and she immediately got bit right back on her buttocks and the back of her leg. And this doesn't happen often, but the shark actually pulled her down under the water, and she remembers it going from light to dark. And then she sort of passed out, maybe.
Yep.
because her boyfriend said she was there for 4 minutes underwater.
Really?
And then she kind of had this vision of her kids and woke up and thought, if I poke the shark in the eye, it'll let me go. She did that, let her go. She popped up. Her boyfriend had already sent people into the beach, which is really important to get help because the timing on these things is really key.
Get the EMS system engaged right away to get them to people who can fix the problem.
Right. Get a helicopter going, whatever you need to do.
Note to self, Matt. You and I go surfing together, and seals start jumping up on the boards.
Yeah, Matt is going to be propulsed by something in his pants to get to shore. But that is terrifying. I mean, she gets drugged down to the black. That is literally the stuff of my nightmares.
How long can you hold your breath?
Not 4 minutes.
I know that's crazy. Especially, I mean, think about the fear and I mean.
And then she woke up and poked the thing in the eye. Oh, man. That lady.
Very interesting.
Oh, wow. What a story. What a story. So, what kind of injuries did she have?
Large tissue loss, massive tissue loss to the back of the thigh, minimal bleeding, and no pain.
I know a lot of these patients said the same thing.
Yeah.
Like, no pain. That's crazy. You got bit by a great white shark and you don't have any pain.
I told you the story earlier. I think it was in Unit 1. A guy, arm pulled off in the conveyor belt accident. No bleeding.
Yeah,
and no pain. Arm pulled off.
I wonder if it's just a mechanism that our brain goes to when it's so severe that we just don't feel it. Shock.
Pain receptors just check out.
Just,
There's no point.
Just shut it down. Shut it down.
I don't need to send messages of pain.
So she was complaining of trouble breathing. Obviously, that had nothing to do with the shark bite. That had to do with the fact
that it could have, I guess. You have massive blood loss. You can get short of breath.
Well, I guess, right? That's true. That's
but
true.
I see what you're saying, though. It probably is related to the
But you got you have to look at all of it, right? She definitely needs volume, but you also might be dealing with a near drowning. Well, you're certainly dealing with a near drowning patient. Remember, there's no difference between salt and fresh water when it comes to drowning. So even though she was in the ocean, it had no other effect. But she was awake, which is good. Good for her.
She was awake, And the lifeguards and the medic, they arrived right at the same time. Initial call was for an animal bite or sting, because there's a lot of stingrays out there.
Right, sure. So. And most of the people that you talk to, the lifeguards and the paramedics, said that they always, whenever they got called to the beach, they would always think stingray thing.
And they also said, too, that they'll say animal bite just because people listening in, they don't want to attract a lot of media attention.
That's right.
So
that's right. We learned that with Keen's story. So dispatched later as a shark bite. That's when the responding people knew, like, oh, okay, this isn't just a little stingray poke. This
helicopter.
Yes, exactly.
Well, that's good to recognize that quickly, and that was a good thing. The quick decision to change transport.
That's right. We talk about, our assessment starts with that dispatch call and that information that we get. Right.
All right. So next, what do we got?
Going to move on to management of this patient.
That's correct. So,
we have a special note.
Yeah, so I thought this is interesting. They actually used the wetsuit to identify the shark based on the tooth mark sizes
and the DNA.
The DNA. It's interesting.
But the other thing is that it was actually, Keen talks about this, is that because the wetsuits are so tight, it actually helps with hemorrhage control.
A little bit of pressure,
Yeah, especially if they have a full long sleeve, which I don't know what this, it didn't look like she had a wetsuit on. But if they have a wetsuit on, and you might want to think about keeping that on, at least till you get them off to the beach, or get them off the beach, because it could help with hemorrhage control. So very interesting. Yeah. All right, so the patient was semi-conscious, like we talked about. What was her skin?
Gray and ashen. Lots of pallor. Yeah. The wound to the back of the leg was exposed. No active bleeding again, but no blood pressure either.
Oof, yeah.
Pretty hypotensive. Again, probably stage 3 or 4 in shock. There's also the issue of the near drowning, too, which complicates things.
That's right. You're dealing with multiple issues, not just the big bite. So we got IVs, like we've talked about numerous times throughout this lecture. We're going to start 2 large bore IVs. Mainly, we're just gaining access so that when they get to the ER for this guy, he can do what he has to do, but we're not pouring the fluid to this lady. She has lost volume, so we're just going to give her a little bit of fluid, maybe some pressors to try to get that blood pressure back up.
Supplemental oxygen was given to because she was short of breath.
That's right.
So the patient was moved to the asphalt away from the beach via ambulance to a loading zone, which is good. And we learned about this too, and we'll mention it again, is you want the patient out of the sand.
That's right.
If you are treating patients on a beach or a sandy area at a lake or whatever, staying out of the sand as best you can decrease the risk of infection.
That's right. Yep. Helicopter assessment, shallow breathing. She's tachycardic. Her BP was 90, so like we've talked about, permissive hypotension. That's actually a pretty good blood pressure for the amount of injuries that she had. Yep. So no more fluids were given, right? They didn't need to give any more fluids. Yep. And then
Well, and it makes sense too, and a lot of this is related to the near drowning as well,
That's
complicated things, but was RSI, rapid sequence intubation, paralyzed, sedated, and intubated.
That's right.
And then airlifted to the hospital to
Let's
get blood.
sedate, paralyze, and then intubate.
That would
Let's
be
make
better.
sure that we sedate first, then paralyze, then intubate. Yeah. There was multiple reasons why this patient probably needed to be intubated. Probably the biggest one, again, was the near drowning. Probably not necessarily the massive trauma. Maybe not, but multiple indicators that she probably needed to be, that was the right thing to do for this patient. Got some vitals here?
Yeah, so blood pressure still looks good, 93/67, heart rate's high. Now, if you look at the shock index here, 127/93, it's more than 1.
That's right.
So, again, we're compensating for some massive blood loss
For
here.
sure.
And she's altered, but she's also the near drowning. Anyway, complicated. So
Lots of issues, And you got some rhonchi in the lung fields,
Some aspiration,
exactly,
probably,
to be expected for sure. Treated for aspiration, near drowning.
Yep.
And this is actually this patient.
Yeah, and you
Wasn't
can
this-
see, and that's the wetsuit there.
Yep.
And you can see saved as much as they could to preserve some of the bite marks to determine how big that shark was.
That's right.
And you could see by the wound there, a wound that size is going to be a large shark. Massive transfusion protocol, 4 packed reds, 4 platelets, 4 FFPs.
That's right. 9 surgeries. I mean, obviously, that is a massive injuries.
Yep.
So 9 surgeries to repair just the initial stabilization surgery. Not even. I'm sure she had multiple surgeries after that as well.
You and I had a patient together.
Yep, I know exactly what patient.
You know where I'm
I know
going,
exactly
right? Because she
what
had 18 surgeries,
Yes.
I think.
Yeah, she had massive chest trauma.
Massive chest trauma. It was not a shark bite. It was
Nope.
a bite by something else.
Fence
and
post.
so anyway, these injuries don't have to be sharks.
Nope.
I mean, this could be a
Yeah,
fence,
her
it
injury
could
was
be-
just as impressive as that, just in a different area of her
was a
body.
lot there, yeah.
That was. I will never forget that call as long as I live.
Lots of antibiotics, physical therapy, counseling too. Can't forget
Sure.
the emotional impact of being bit by a monster like this.
And being pulled under. I still am just thinking of looking up and you just see daylight dwindling away from your life. Oh,
But doing well and with a
Terrifying.
great attitude. You know, that reminds me of Keen. You know, we're going to talk about him more later, but what a great attitude in that kid. This
Yes.
obviously this lady here, a survivor of
can't
a
survive this.
horrific injury.
Yes, you can't survive this without a good outlook and a good attitude.
Well, that's case
hugely important.
2. Oh, no, sorry. That's case 1.
That's right.
Case 1 in Unit 2. Or no,
right.
sorry.
Yeah, Unit 2, Case 1.
Section 2.
Section 2, Unit
Who knows? I'm just glad you're here. Let's go to Section 3 for case number 2.
All right, let's do it. Before we get to case number 2, let's talk about some TXA.
Very important medication for hemorrhage patients.
Yes, absolutely.
So TXA is an antifibrinolytic. So what that means is it inhibits the formation of a clot. And actually the breakdown of the
breakdown,
formation of the clot.
Right.
So that TXA can really help a patient maintain those plugs.
That's right. It stabilizes that clot because these clots will start to break down with time.
Yeah.
And so that's why it's important to get that TXA on board. It'll keep that clot in place to those areas where we might not be able to get to keep those platelet plugs like we talked about in Unit 1 where they need to be.
Now, before we get to indications, I thought it was interesting. I learned that this is really only FDA approved for 2 things. Obstetric and dental emergencies. These are off-label uses in trauma. What we're using it for and talking about is not FDA approved. However, the literature backs it up, and it's certainly standard of care.
That's right.
But technically,
Follow your
the
local protocols.
Yeah,
if it's in your
definitely.
protocols,
Yeah,
you're safe to use it.
Use it appropriately.
And it
So-
is a very safe medication
It
to use
is,
when
it
used
is.
in it's a very safe medication.
So what are the indications?
Yeah, used in major hemorrhage, used in cases where there's major hemorrhage, like all the cases we're talking about
Correct.
today. There's a couple of other indications.
So significant trauma with suspected internal or external hemorrhage is something you might see, something you might not see. But again, looking for those clues in the assessment, like we talked about in Unit 1, can give you the indications for treating a major hemorrhage.
That's right. Hemorrhagic shock, risks of exsanguination. You walk up, you see a lot of bright red blood all over the ground. When you walk up to the patient, you know, like, ooh, this is probably a patient that's going to need some TXA. Again,
and I will say though that all of these studies that were done that showed a benefit we're studying patients who would have qualified for a massive transfusion in the hospital. Yeah. These aren't patients that just had a cut. I mean,
yeah, right. Normal blood pressure and normal heart rate.
Right.
Yeah, these are not your these are not TXA candidates.
Yeah.
Suspected or confirmed postpartum hemorrhage.
Good.
We talked about that in Unit 1, how that's one of the main reasons why somebody can bleed.
Bleeding related to surgery is another one of the things we talk about with invasive procedures.
That's right.
And then evidence of hyperfibrinolysis, so trauma-induced coagulopathies, like disseminated intravascular coagulopathy. DIC is classic for this, but the point is that if you see evidence of people bleeding out of every hole in their body, you might want to give them some TXA.
Think about
basically
some TXA.
do everything you can.
Yeah, exactly, because you can't put a tourniquet on their eyeballs. So dosing. I mean, we did once in a lecture. I had a tourniquet on my eyeballs. Dosing, remember?
Right. Yeah,
remember
I
you
do remember that.
threw that shock tato at me? Yeah. It's like you talked about earlier. We used to put this in a 1,000 bag, but then you're having to give all this fluid to get your medication in. If you put it in a smaller amount of fluid, you're still getting the same amount of TXA with less fluid, which, as we've talked about numerous times, is good.
Yeah, and if you and your agency are using a leader, right, you might want to talk to your medical director or EMS division to change that protocol to deliver the TXA in a small amount of fluid.
That's right.
We do not want to give a lot of fluid to these patients.
No, we do not.
No, it starts to add up. Now, the second dose, 1 gram over 8 hours, but follow your local protocols.
So timing, pretty important.
3 hours, really. It's within 3 hours, ideally.
Of the injury.
Of the injury,
yeah,
right.
Yeah, for sure. Delayed administration is associated with reduced effectiveness, may increase the risk of adverse events, like a thrombolytic complication, something like that. They might throw a PE or something like that.
Yeah, which is, we're going to get to that as a contraindication, but it's important to get it done as quick as we can.
That's right. That's right. So contraindications.
Yeah, active blood clots. So whether it's a DVT, a deep varicose vein thrombosis, or a pulmonary embolism, et cetera, we don't want to inhibit the breakdown of clots that are there, right? So,
that's right. Yeah. That's right. Isolated head injuries with no systemic hemorrhage. Right. Obviously, we don't want to push TXA on those kind of patients.
No, and known hypersensitivity. If you're allergic to TXA, obviously you shouldn't give it.
Yeah, which I don't think, that's pretty rare, I would think.
Yeah, I mean, if you'd had it and you had an allergic reaction to it and somebody's telling you they're allergic to TXA,
that's right.
Don't give it, but that would be weird.
That's right.
It's good to know.
Patients with head bleeds, risk of cerebral ischemia, obviously, we don't want to give it to those patients.
Yeah, and so when we get to evidence, some of the studies, the CRASH 2 trial, they showed that TXA reduced the mortality with patients that were qualified for the massive transfusion protocol, significant hemorrhage.
Right. Guidelines, the WHO, I love that band.
World
Health Organization.
That's not what the WHO stands for with the WHO you're talking about.
Right, different WHOs. Yeah,
different WHOs.
That's right, different WHOs. But they recommend early TXA, again, in trauma-induced hemorrhage is very effective. So within that 3-hour window, they're hypotensive, they're meeting all the criteria, get that TXA on board, put it in a 100 ml bag. Yep. Really, really effective.
So now that we've finished talking about some TXA, we're going to get to our next case. Yep. But first, we're going to throw it to Dr. Schwartz to introduce this.
Another interesting case. Now, this one wasn't in this area. This was up close to Monterey.
Correct, at a place called Lover's Point.
Lover's Point.
Yeah.
Not a place I'd want to take my wife, but after you told me about this case. So tell us about it. So 62-year-old swimmer.
Yeah.
Now, actually, we talked about this before. The most common injuries, shark bites, are for surfers and swimmers.
Yeah.
So this is a swimmer.
Right, and the swimmers swim, beyond the surf break, so they're more in the water where most of the sharks are. A lot of the sharks are not in the waves.
Kind of like where we were.
Yes.
Okay, keep going.
Again, I didn't tell you because I would have never gotten you out there. So.
Oh my word.
But anyway, he finished his swim, mile and a half swim, 150 yards offshore, and a 15-foot great white shark bites him, and supposedly there is security video that shows the shark completely coming out of the water, turning around and ducking him 12 feet into the underwater.
Oh.
Yeah.
What a nightmare.
I know. And then immediately the shark lets him go.
Really?
But it's like from you to me away from him, and he's shaking his head, which sharks seem to do for some reason. And he kicks it in the face and it goes away.
Wow.
And he was pretty torn up. He got bit across both legs. The shark's, biting him like this. So back, abdomen, and one arm. Fortunately for him, there was a police officer and a nurse in the water.
Wow.
There was a guy on the beach teaching beach safety to kids from Kansas. I don't think they're going in the ocean soon.
A live practicum.
Yeah.
Hey kids, come over here.
Exactly. And so that guy who was on the beach did something smart. He took 2 surfboards out to go get the guy. And then the police officer and nurse helped them all push the guy in. Again, no first aid was done on the board, but fortunately the guy made it. But when he got on the beach, there were 2 ICU nurses and an ER doctor.
Wow.
Yeah, and they applied 3 tourniquets out of t-shirts.
Really?
2 across each leg and 1 across the left arm.
Not definitive, but at least slows the bleed.
Yeah. I don't know exactly how they did it, but it worked pretty well. And then EMS was there pretty quickly, but it was a 28-minute drive. For some reason, there's no helicopter to the trauma center. So he got there within the golden hour. He had borderline vital signs again, like, you know,
Gray and
90-ish,
ashen.
Gray and ashen.
Yeah.
And he got, I think, was it 12 units of packed red cells, FFP, and platelets, so the massive blood transfusion protocol.
Yep.
So he again had bled out at least half his blood volume or more, and he was replaced 3 times over multiple surgeries.
Wow.
And he ultimately did okay. He just had a femoral nerve that was cut that they're trying to fix, so he has a little trouble using his quadricep, but otherwise is pretty good.
And it looks like he has a real supportive network of people around him based on that picture you showed of him there. Well, great case. We got one left, and then we got an interview.
Well, we've reached the case.
The final case with Keen.
Yes, the case that we have been following since Unit 1. You've been following along with us.
Yep.
The story of Keen Hayes, young man bit by a great white shark.
From the introduction of him to his lobster diving to Palomalu, the bite,
all of
then the bleep moment. And we're going to review some of the treatment now and look at how some of what we've been learning was employed to save Keen's life. This is great. This is super important.
Super exciting. Before we get to that, we're actually going to start at the beginning with the dispatch of Keen's actual call, hear that, and then we'll go through the case.
Let's go.
We have a shark attack. I'm asking for a helicopter. We need to airlift somebody out for a shark attack.
This one really feels real. Hear the dispatch,
yes,
right?
It feels like we're on the call, going to this. So 13-year-old male was lobster diving, like we've said. He was at dawn. It was foggy, about 9 feet of water.
Yeah.
Crazy kids out there diving in the...
Never done it before, like you said.
Oh, that's got to be terrifying.
And then hit by a great white.
Bam! Just comes in.
No pain.
No warning.
Just thought his buddy was pranking him.
Yes, isn't that crazy?
Yeah.
Didn't realize it till he surfaced and saw all the wetsuit and the injury.
Yeah.
Swims to a kayaker about 70 feet away. Because I guess, if I remember right, the kayaker was a little bit closer to shore.
Correct.
And he felt like that was a little bit of a more immediate way to get some help.
And the kayaker, of course, had his expletives to share before taking him back in.
Which I can't say that I'm blaming. I might have said the same in that situation.
Yep.
And then so the kayakers took him into shore. There was another kayaker that kind of came in, and they helped him, took him into shore. No first aid initially.
Yep. Blood was spurting.
Yep.
Yeah.
So what's that tell us?
Arterial
Tourniquet,
bleeding.
if possible. Arterial bleeding, exactly. And then there was lifeguards nearby, which wasn't. Go ahead.
Fortuitous. I mean, this was normally they aren't there at this hour of the morning,
right?
But they were there because they had some sort of a surf contest or whatever it was.
Yeah.
So the lifeguards were there,
Thankfully.
and the call for animal bite or sting came out. Thinking stingray, because it's very common in this area.
That's right.
But that obviously wasn't the case.
That's right.
Something a little bit bigger.
And then dispatch notified them, like in the last case, after they got the initial call, that it was actually a shark bite.
Right.
And that's when they knew, like, oh, okay, this is probably something pretty serious. And, You know, BLS or ALS, they're calling for a helicopter.
You know, we talked about this yesterday about being able to differentiate sick from non-sick from the door. You know, immediately upon seeing this patient, you know he's sick.
When you say shark bite, I'm immediately thinking sick. Yeah.
You know, I don't know if this came out clearly, but I mean, his arm was detached. I mean, it really was. Joint was totally exposed and disarticulated. Yeah. He's awake and alert and not having any pain. So this was a really significant injury to the left shoulder girdle.
Yeah, and he actually even got hit in the neck too, and it came very close to his jugular.
Yeah, that's right. Yeah. I had one tooth that kind of grazed him here, and then
one of those
some sort of a puncture.
5 rows of razor blades. Oh man, what a tough kid. Cut the wetsuit off. That actually, we talked about saving the wetsuit, but he talked about that in his interview. I'm not sure if we played that exact clip, but that again, like we've talked about, keeping that wetsuit on while they were bringing him probably helped him from bleeding out too much, which is pretty cool.
It did, and I still, you know, I wonder, because a lot of the, you know, I guess conventional knowledge for me as an ER doctor is to eliminate that contaminated,
get it off
material and get, you know, sterile dressings on it. Get it, you know, keep it as clean as possible.
Yes.
But there's also the pressure component, which I guess you're going to have to use your knowledge to, you know, critically think.
That's the difference between your world and our world, because we don't have that sterile environment.
Well,
unfortunately.
You know, but you got 4x4s and stuff like that. You can.
But sometimes when you're in the sand, you know, you're down in the sand and the dirt, you got to do what you got to do. But it's very.
That's funny.
Yeah.
So they did apply the combat gauze, a medicated gauze. It'll help blood clot up, and we got some towels, oxygen, protected from the sand, which was key to you know, reduce the risk of infection.
Yeah, they kept him kind of on the surfboard kayak, so these people knew not to get him into the sand. And then again, the providers called. There was actually a paramedic and an EMT on the ambulance.
Correct.
They called for a helicopter because they knew that he was going to have to go to a large trauma facility, and it was far enough away that he was going to need to be airlifted there. So, so again, think about where you are in relation to trauma centers when you're looking at these major hemorrhage patients.
Yeah, you want to know what the capabilities are of your hospitals around. Speaking of hospitals, the hospital course for Keene, hemodynamically stable when he got there.
Yep.
The decision was made to perform the definitive surgery initially.
Yeah. Well, they actually, I remember he said they had different. They had 3 different options, I think they said, of surgery for him. And because he was young, because he was stable, they decided to kind of do everything now, but they had to wait for these different surgeons to come in and all kinds of stuff. But and now we're going to actually hear from Keene his perspective. We always look at and talk about our perspective as the first responder. Now we're going to hear the patient's perspective.
Yes.
This massive traumatic event, massive injury to this guy, and now we're going to hear what it's like to be one of these patients.
Yep.
And instantly, I just started screaming for help. I was just, help me, grabbed my arm like this, and just started swimming this way. Finally, I reach a kayak that's about probably 75 yards away from me, and I just hit the kayak, grab it with my right arm, like this arm's still in like this, and I just do one big kick with my feet and pull myself in and just flop and roll, and this side's up. And then all I hear is the guy on the kayak just go, "Oh shit." And they just kept asking me like, "What's your name? Where are you from? What are you doing today?" You know, just keeping me kind of alert and orientated. And I just knew, like at that time, like something was up and I need to stay calm. He pulls up in a truck and I just felt one of those big wool, like warmth blankets. I just felt that get wrapped around me, and I just felt a ton of pressure on my side. And I was like, ooh, doesn't really feel good, you know? They just applied pressure on my open wounds. They put a O2 mask on me, talking to me, trying to get me, you know, to stay with them and make sure I'm talking, and, you know, my airway wasn't affected or anything like that. And they weren't able to do a tourniquet. Billy said he wanted to do like the quick clot gauze, like the gunshot that kind of expands, but since it was so wide open, it would have just made more of a mess, and there really wasn't anything to do with that. Remember landing in the actual helicopter, they pulled me out, and it was like a scene from a movie, like where you see the blades going by, then you see the sky, and then you go into the doors, and everyone's around you, you see the lights passing by. I just remember kind of just sitting there, waiting for a while, and waiting, and then finally they put me out.
Wow, what an amazing kid, an amazing story. Hope you guys enjoyed it as much as we did. We're going to summarize this stuff with a little bit of
content left.
Morsels.
Morsels. We
Not
got some
pearls.
morsels. Not pearls. Pearls are mollusk irritants. We are talking about some delicious little pieces of food that we get to eat.
That's right.
Little tidbits.
That
morsels.
we've been slowly feeding you over the last 2 hours. So, hemorrhage patients.
Yeah. Hemorrhage patients. The first thing we can do managing a hemorrhage, obviously, is pressure.
That's right.
You know, when I have scalp lacerations in the ER, oftentimes what I'll do is I'm trying to figure out what's going on, to see what's going on.
Yeah, 'cause the hair-
I will stick my finger in areas where I think that blood vessel is under the tissue, and when that spurting stops with the finger pressure, I know that
There it
artery
is.
is under there,
Yeah.
right? And we'll keep my finger there, and that's actually saving the patient's life, right?
Yeah.
It's and then I can throw the stitch, or whatever, to stop that that bleeder. But the direct pressure is what that is, and it doesn't take a lot of fancy stuff. It just takes your hand.
Yeah, well, it depends on the size of the vessel.
Depends on the size.
Yeah, if you're dealing with a femoral artery, it's probably going to take more than your hand.
But this is the first thing we use, right? Pressure.
That's right.
and then arterial bleeding, we talked about that, but
Talked about
obviously
that
pulsatile
extensively.
flow of
Yep.
bright red blood.
Right. Not good at estimating blood loss. I don't think there's really anybody that's good at estimating blood loss. So just look for objective signs of massive blood loss. If you just see a little bit, it's probably fine. Think about like a 2-liter. That's kind of how I picture it in my mind. What would a 2-liter bottle of Coke look like spilled out on the ground? That's a lot of fluid.
But we're not good at it. They studied this. There's a study done, and they took a fixed amount of blood and spread it all over, and they had multiple people come in and guess. And the guesses were all over the place. We really don't do well at that.
No.
And like you said, we should stick with the objective signs.
That's right.
With the vital signs, physical exam
Skin
signs,
color,
the
all
history,
that,
the mechanisms. That's where that's where the truth is, and that's
right.
what we should act on.
Exactly. Hemostatic dressings and wound packing. Remember again that those are going to be more for your junctional areas.
Yep.
You've got a penetrating trauma to the shoulder, to the groin or hip area. That's where you're going to use those hemostatic dressings. Do not use those in an abdominal injury. If you have a gunshot wound to the abdomen, we are not. It's just too big of a space, and you're shoving stuff in there. You're going to damage vital organs and probably make the problem worse. So that's kind of where we use those.
Yeah, we're gonna do the best we can to stop the bleeding, and these dressings can help, but be careful.
Yep.
You never stick your hand where you can't see it.
And if you don't have hemostatic dressings, it's not a big deal. Get some cling and just start feeding that cling into the hole, and you pack that hole as tight as you can.
Yep.
And that's because we'll throw that hemostatic dressing in there first, and then if there's still room in the hole, we'll follow it up with cling.
That's good.
And wrap it nice and tight.
Good advice. So, we've mentioned this before. It's never hurtful to say it again. Early identification.
Yeah, that's right.
I think earlier we said early recognition, but early identification, early assessment, and finding those injuries, and being prompt about getting them to the place where they can be fixed.
That's right.
Rapid transport.
Yeah, whether you're BLS, ALS, critical care, doesn't really matter. We all have to identify the problem. If you're BLS, you're looking at either getting more help there on the scene or getting en route quickly. And really, if you're ALS or critical care, you're getting en route. All these fancy skills that we're doing, you should be doing those skills en route to the facility. We talked about the signs of shock, the stages.
Hypovolemic shock.
Yeah, that heart rate's going to increase first. Typically, the pump's going to try to speed up to compensate for that. And then altered mental status, you're a big...
Yeah, if the brain's not getting blood, you're going to be altered. And don't forget, if you have a pregnant patient, make sure you lay them on their left side. Be careful. You could block those big vessels down there.
Another thing is look at the patient's history. If you have an older patient that's on medications like beta blockers that's going to keep their heart rate low, remember, they could still be in shock with a heart rate of 60 or 70 because they have medications prohibiting their heart rate from increasing.
And that may or may not be an assessment question. Those beta blockers can really get in the way.
There you go. Wink,
be
wink.
Be careful with this.
Don't forget about airway management.
No, don't forget about airway management. This is important.
That's right.
That's the A in March. Massive hemorrhage first, but airway management can be a killer if you miss it. So
that's right. Hypoxia is another big problem with these trauma patients for sure. Lethal triad.
It's another thing to remember.
Yep. Hypothermia, acidosis, and coagulopathy. I love that word.
That was amazing. I love that. I bet you can't say that again.
Oh, I can't say that again. It's like parlor. I hate all these big fancy words.
But it doesn't matter. It's the coagulopathy or whatever you said. It's all, we don't need to know specifically what they are, but we do need to know though is that when we can't stop the bleeding, it's lethal.
That's right.
And obviously, if you lose a lot of blood in a traumatic situation, you're at risk of acidosis, which screws up a bunch of bodily functions and can lead to death. Yeah. And obviously, the temperature.
Hypothermia. Keep these patients warm. We keep forgetting this. Yeah. Your car wreck victims, you get them in the back of the ambulance, you're cutting all their clothes off, all that stuff, and they're losing volume. They're losing the thing that's trying to keep them warm, right? Carry blankets in your ambulances. Get these patients bundled up. Keep them warm. Doesn't matter what the temperature is outside. Make sure you're keeping your patients warm. It's just as important as volume and oxygen and all these other things that we're talking about.
And of course, this is kind of a fun thing we learned. Shark in the water, and that's the universal sign. As scary as it was to be out there, Dr. Schwartz was telling me that the sharks attack from underneath and from behind. And so when I was out there, I was looking around.
And then you're never going to see them. Those suckers are swimming at you at 50 miles an hour. Here comes a truck ready to eat your leg off.
Well, Matt, it's time to do our summary.
Yep.
ACE learning points.
ACE learning points. So the main thing that we talked about today, or over the last 2 units, I guess, is being able to assess major hemorrhage is crucial with these patients. Yep. Being able to early identify that you're dealing with one of these hemorrhagic patients.
And if you have an extremity hemorrhage, tourniquet placement is the cornerstone.
That's right. Pressure first, like we talked about, pressure first. But if you need that, if you see that obvious arterial bleeding, get that tourniquet on quick. We talked about wound packing, pressure dressings, all those kind of things. Again, these are all BLS skills that anybody can do.
And rapid transport.
That's right.
Rapid transport to a place they can get fixed.
That's right. All the fancy skills that the ALS and critical care folks can do, they can do that en route. We got to get these guys to a trauma surgeon because they got to fix those injuries.
Because this was such a unique course, let's send it to Keen for one final thought of encouragement to our listeners and students, and then we'll finish this up.
Let's do it.
Like in this line of work, sometimes it could be hard to see someone in such critical condition, and in my case, just get flown away in a helicopter. And after that, I reached out to the people that helped me. I just tried to tell them, like, hey, thank you for what you did. You being there early on a Saturday completely saved my life, and without them, I wouldn't be here.
Pretty cool lecture. Long time in the making. This was pretty cool. Yep.
And so many people to thank. Dr. Schwartz, our medical director friend out in San Diego.
Dr. Lowe.
Dr. Lowe at Cal State Long Beach, world's shark expert. So generous with their time. And then Dr. Schwartz set up a lot of meetings with lifeguards, the paramedics, and then the Hayes family. Keen. Amazing. Added so much to our lecture. I hope you guys learned a ton.
Yes.
Do you have a highlight, Matt, before we close out?
Well, we talked about it. Yeah, Keen. That was I think Keen was just he was the highlight of the whole
highlights?
Thing. He was I don't know. He was the highlight of everything. I think so. His story is amazing. Absolutely incredible. You obviously got to go and swim with great whites and do all those kind of things. I don't know if I'd say I'm necessarily jealous of that. But, I mean,
that was
cool.
my highlight.
You get to say that you did it.
Yeah, and I think that it was like we were learning with the sharks. It was just I knew they attacked from the back and from underneath, and I was just constantly looking around. It was freaky.
An experience
scary.
You'll never forget.
Never forget
sure.
it. Yeah,
Well,
amazing.
thanks to everybody that helped us get this done. Thanks for watching. Hope you enjoyed this lecture.
Yeah.
Assessment questions. They got a bunch of those.
Yeah, they got to take your assessment questions.
That's right. Well, we'll see you guys on the next one.
Be safe out there.